I uploaded some still images yesterday on my Facebook page, and I was taken aback by the number of comments and likes. And most of the comments are urging me to upload this video as soon as possible. So therefore, I've sacrificed my evening when the Premier League football is restarting tonight. In America, I'm meaning soccer. Our National Soccer League has recommenced tonight in order to edit and narrate this video. So this video, the title of it, I have named it Earwax Excavation, an expedition into one man's ear. And if you haven't seen the still images of the amount of wax that has been removed from this gentleman's ear, I urge you to watch the whole video, and at the end of the video you will see 8 still images and you'll be quite gobsmacked and taken aback by the vast quantity of earwax, and actually dead skin. It's not just earwax, there's also dead skin. So let me provide you with a brief background on this particular client. He called up yesterday for an emergency appointment. He's been experiencing excruciating earache and severe vertigo, and also unilateral tinnitus, which is a ringing or a buzzing sensation that's inside your head or inside your ear, so it's not as a result of any external stimulus. When the patient attended, he was actually holding the right side of his ear and head because he was in that much pain, and he was also finding it very difficult to walk in a straight line. He was veering off to the right side, so it had also affected his balance. Your balance is a very complex system, and it's not just your ears that regulate your balance. It could be the back of the brain, that is the control center for your balance, your cardiovascular system, your musculoskeletal system. These are all very important to your balance, as is your visual acuity. They all play a role in your balance. So for this particular client, I couldn't guarantee that it was his wax impaction causing his balance issues, but it may well be. So you can imagine how cautious I had to be and how delicate and sensitive I had to be. The patient was already in excruciating pain, so I'm only going to be unfortunately adding to that pain by putting instruments in the ear. Whenever a client does come with an earache, I try as often as possible to use suction, because it's possibly the least uncomfortable technique of removing wax. When you use hook scoops and forceps, you're having to get in behind the wax, put pressure against the ear canal, and you can quite easily add to that pain already been experienced by the client. So just going back to just the client, he mentioned to me that he had an operation around 20 years ago, but he didn't really know what operation it was. He just told me it was to do something with skin. It was very vague, and one of the things I thought it may have been, not immediately, but just during the course of the procedure, is that you had a mastoid cavity. A mastoid cavity is when the mastoid bone is drilled away by an ENT surgeon. So the mastoid bone is the bone on the posterior canal wall, and you can actually feel the mastoid bone behind your ear. So if you elevate the pinna, which is the external flap, and the satellite dish of your ear, and position your finger behind that, you'll feel a flat surface there, and that's the mastoid process, and that region there is the mastoid bone. The mastoid bone is porous, it has air gaps, so many people who suffer from a middle ear infection, that infection behind the eardrum can get absorbed by the mastoid bone, and that is then called mastoiditis, and that can cause severe earache behind the ear, and you can get visible inflammation and edema, so bruising, swelling of the area behind your ear. And if that can't be treated with antibiotics, surgeons have to drill that bone away, because that infected bone, the infection can spread across the mastoid bone, and the mastoid bone makes up a part of your skull, and if it's left untreated, it can be life-threatening. You can develop meningitis, because the meninges, the fluid around the brain, can get infected. So it is a very serious operation that's performed by ENT surgeons. However, typically, if you've had a mastoidectomy, especially many, many years ago, you often see an indentation of the bone behind the ear. So where the mastoid bone is, because it's no longer there, you can see a visible crater. With this client, there wasn't any. I have come across children who've had mastoidectomies, and as they're older, that indentation is also not visible. But the gentleman was 50 years of age, so you would have had this operation in his 30s, and you would expect someone with a mastoidectomy to have a crater or an indentation behind the ear. In modern days, I know a lot of surgeons now aim to fill up that indentation, that crater, by filling it with fatty tissue, so it's not visible externally. And sometimes also internally, the region of the bone that they've drilled away, they try and cover that up so it's not visible. So the outer part of the earwax, the patient had been using some olive oil, so it was a bit softer. So I managed to remove the very lateral part of the wax, but the more I was working in the ear, I realised it's not just wax. He had keratosis obturans. So keratosis obturans is a buildup of dead skin, keratin, that collects and coils and impacts within the ear canal. The human ear, the skin that coats the ear canal, as it sheds, it should naturally migrate. So your ear is like a conveyor belt. The skin sheds and it migrates outwards, then you get another layer of skin forming underneath, and that also migrates. With people with keratosis obturans, it's very difficult for that skin to migrate. It could be a genetics issue. I know there's cases where people have undergone radiotherapy and they lose the ability for the skin in the ear canal to shed and migrate. Also, people with mastoids, mastoid cavities, because of the enlarged area within the ear canal, it's much more difficult for the skin to migrate, and instead it collects. Typically, patients who have had a mastoidectomy are often and routinely seen by ENT in outpatients, so their mastoid cavity can be examined and any skin formation or infection can be removed. It's very vital. Once you've had that bone removed, you really don't want another infection there, because there's not much bone to work with, and it's more likely for that infection to spread again to the skull, to the meninges, and causing serious health issues. So you can actually see the skin there, that's the white bit, and it's a very spongy, elastic type of skin, and it was a very thick layer, and it really had impacted the wax and the skin in the ear canal. I wasn't really going really well with the suction probe, so I've now resorted, I had no choice really but to use other instruments. The client, obviously there's no live audio, but he was finding this uncomfortable. You could see that I wasn't actually making contact with the ear canal wall at all. Instead, I was trying to get into the middle of the dead skin and wax, trying to rotate the hook, hopefully getting a grip and pulling it out. But this wax and dead skin, this keratosis obturans, was extremely elastic, and it was adhered to the canal wall. There was an argument of using crocodile forceps, but with forceps, you can just tell by the consistency, it's not firm enough. It's almost, if I used forceps with this, one of two things would have happened, or maybe even both. There wasn't a leading edge, so imagine having a wet tissue and you're using forceps, and you just got enough grip on the tip of the tissue. You can't get the forceps kind of enough surface area over the tissue, and so you've got forceps on a wet piece of tissue and you're pinching the edge and you're pulling. You're just going to shred that. You're not going to pull this this debris out in a big mass, and you'll be there all day doing it. And also, if I were to try and get enough grip, I would have to force the bottom end of the forceps against the canal wall and then slide that against the canal wall to get enough grip and surface area. And as I said, this patient was already finding this uncomfortable, and that would have been extremely uncomfortable. So for two reasons there is why I didn't use forceps. So for all those armchair experts and those who have graduated from Google or YouTube University, that's why sometimes we don't use instruments that you feel as though we should just by viewing a video. we're with the client, we can sense how they feel. I've always got one eye on the client. Obviously, they're telling me if it's uncomfortable. So for me, again, if the patient's uncomfortable and there's no leaning edge, I don't use forceps. And again, you can just tell by that consistency. It's too soft, it's too spongy. You wouldn't have got a firm enough grip to pull that. I've had no choice here, but I've tried to go to the roof of the ear canal, the superior part, just to try to get this ear hook inside that kind of opening, but he was just finding it a bit uncomfortable, so I was just going back to the middle part. Therefore, I just decided to resort back to the suction probe at this stage. And you can see that flap of skin. It's although I'm lifting it, I'm trying to peel it off the canal wall. As soon as I let go of the suction probe, that skin will just flap back against the canal wall. It's almost like a trap door almost. You lift it. Now, if that skin was like that without the suction probe, there's an argument there I could possibly have gone in with some forceps. But again, you can see the bones exposed there. The other issue with dead skin in the ear, which hasn't shedded, that skin can get infected and it can cause erosion of the bony part of the ear canal, again making it a lot more sensitive. And here's me ferociously trying to tug this off, trying to really lift this dead skin off the canal wall. Quite often the suction probe would get blocked because that wax and keratosis obturans is very mushy, very spongy. And again, I'm referring back to, that's another reason why we weren't using forceps, because the consistency wasn't right. So quite often in this procedure, you'll see me coming out, and that's purely because the suction probe has been blocked and I've had to use a cleaning rod to thread it. If you remember from a minute or so ago, that skin, I did manage to lift it off the canal wall, but when I went back in the second time, that flap of skin had just, like a trapdoor, collapsed itself back onto the canal wall. So I've decided to put some drops in here. I think this is olive oil drops in the first instance. Actually, I think it's sodium bicarbonate. Previously, I put some olive oil. I find sodium bicarbonate works really well with skin conditions, so otitis externa, dead keratin, keratosis obturans. Olive oil doesn't tend to work as well with skin conditions. It's almost as the skin is repelling it, and so once you've suctioned the outer layer, the inner layer still not absorbed any of the olive oil, where sodium bicarb, it's water-based, so the viscosity is less than olive oil, and you find that the sodium bicarb can actually get in the little cracks and cravets around the wax, so it can get in between the canal wall and the debris and penetrate a bit deeper in the ear. So we're now on the posterior canal wall, and this is kind of when I first realised actually this client, his operation was a mastoid. I mean, it could have been that he had two operations. It could have been, because he did mention to me the operation he had 20 years ago was to do with skin, and that's all he referred to. A mastoid isn't actually to do with skin necessarily anyway. It's to do with infected bone, the porous bone. So it could have been the patient 20 years ago had another case similar to today, keratosis obturans, and he underwent a general anaesthetic procedure because it was too painful for him to have it removed. I mean, I know of a few clients historically, previously, who have had to have keratosis obturans removed via GA. And if you see a lot of the videos, the Chinese specialist, I believe a lot of their procedures are performed in a general anaesthetic, hence why they can use scoops and hooks very deep in the ear because the patient's not awake and they're not going to feel any pain. So just if you missed that, I actually went in with a Jobson horn and I managed to slide it into the roof of the ear canal to elevate and almost retract that keratosis obturan that's stuck against the canal wall. Again, he did find it quite uncomfortable. You can imagine this ear is completely and utterly packed with coiled dead skin and wax, and it's compressed. So any compression, any instrument that's going in between the canal wall and the debris, it's going to add to that compression, cause severe pain. And even with the suction probe, this dead skin and keratosis obturan is compressed against the eardrum. So as soon as you're putting any pressure onto this debris, this occlusion, it's actually pushing against the eardrum as well, because it is really compressed and coiled and impacted, as I mentioned. So the Jobson horn did help me to lift some of that. You can see the white dead skin at the top, and you can see some of the skin where I'm on now with the suction probe. It's slightly discoloured, it's more of a yellow, and that's to do with the oxidisation process. So the skin that's coating the ear canal, the reason why that's white, because that's fresher, newer skin formation, whereas the skin that I just removed there, that's kind of an old layer of skin that hasn't managed to migrate naturally, and it's oxidised into a yellow colour. So I've been talking for 16 minutes now. I'm going to just have a little break to have a sip of water, and I'm going to just get you to kind of watch what I'm doing here. And again, I'm just tugging away, trying to remove some skin. Hi guys, I'm back. So I've just had a sip of water to rehydrate my throat. You may have seen there, I did manage to remove a big piece of dead skin. So I'm just going on to the posterior canal wall. So this is where the mastoid cavity is. You wouldn't normally actually see this cavity. The ear canal is not as wide as this, and because that bone has been drilled out, it's enlarged the posterior, the back part of the ear canal. And I've used an ear hook quite well there to remove large chunks. And I know it is a bit painful for the patient, but we had no real choice. It was manageable pain. He wasn't screaming, jumping. Obviously, whilst doing the procedure, I was prepping him. So the bits where I felt it would have been slightly uncomfortable for him, I did warn him so he can mentally prepare. And I must admit, I mean, he did fantastically well. Imagine if this is your ear and it was this impacted and you had so much earache even before you entered the room, and someone's poking around in your ear. Obviously, I know what I'm doing, so it's not anyone anyone just poking around your ears, but it can be a difficult sensation and an uncomfortable experience. Managed to remove a big chunk there, and as an audiologist as well, I'm not able to anaesthetise the ear. So some ENT doctors, surgeons in the UK, are able to inject lidocaine. So lidocaine is a local anaesthetic, and dentists commonly use that, and that could have provided a bit of a numbing effect in the ear, and that may have helped speed up the process, because the specialist wouldn't have had to be as cautious as I am really. They will be able to get in there, be quite aggressive without having to worry about the patient and their pain threshold. But in the UK, and I'm not sure whether that's also the case in America, but audiologists currently are not able to prescribe. There's been a lot of talk about audiologists in the UK being able to prescribe certain medications for certain ear conditions, such as otitis externa. It's something that I think we need to consider, especially as though a lot of GPs in the UK, through no fault of their own, I mean, obviously I do ears day in, day out, and naturally, if you do that, you gain an extreme amount of knowledge. And obviously, my training as an audiologist is specifically based on the ear, but some doctors are not always that. I'm trying to think of the correct word here, but clued up as the ears as the doctors. And again, it's not a criticism at all. I can totally understand why that would be the case. GPs they're general practitioners, they need to learn a lot about everything really. So you can never imagine a GP, unless they've got a specialist interest in ENT, being fully kind of in the loop about ear conditions. I can't excuse all GPs. Some GPs, I've had GPs in the past tell patients they've got wax, they can see it, and the patients come to me and there's no wax, and I've had to take a video, upload it onto the patient's phone so they can go back to the GP and actually show their ear. In fact, they had other ear conditions that we evaluated and tested for. So, sorry, I've just gone off tangent there a bit, but just want to go back to the procedure. So I just put some more drops in there. Some people might find this a bit boring, but this is not an entertainment video. This is a clinical procedure. I don't do this for fun. It's not a comedy channel. This is a medical procedure that we're performing, and again, I make no excuses if people find this a bit boring, because actually this is what I do. This is the complexity of cleaning someone's ear out sometimes, and This is an educational program. I've had a lot of specialists from around the UK and America messaging me privately, thanking me for this YouTube channel because they feel it's enhanced their own practice by watching my procedures, the techniques, the tools as and when I use it. So again, I've just gone back in with the Jobson horn. I'm just trying to get underneath this, the keratosis obturans, trying to elevate it, and you can. I don't know whether you can tell by watching the video how much force I'm putting there. It's obviously sometimes difficult to kind of experience that by just watching a video, but I was having to put a lot of pressure and force to the point where that Jobson horn, it was almost like a pole vault. It was bending. The instruments we use is made of carbon fibre, so they're very sturdy. They are single use, obviously, and it just shows how impacted this is. And this is a great image here. You can see the skin coils there as I'm removing that. And that was a huge chunk. And when I removed that, I thought, bingo, that's it. I've cleared this gentleman's ears, but I went back in and to my horror, there was a lot more. With keratosis obturans, you do find that there is a point during the procedure where you remove a piece of dead skin or wax, which then makes, it's like a Jenga effect. You pull one of these wooden cuboids off and everything tumbles, and sometimes you find that with earwax removal procedures, especially keratosis obturans, there comes a point where you remove just a piece of dead skin, which you may feel is quite insignificant, but I think what happens, it reduces the compression and the impaction inside the ear. So all the remaining skin relaxes, it's no longer compressed as much against the canal wall. So when you do try and lift it, it's a bit easier. It's not springing back upon itself. And I think that piece I moved, the big piece a minute or so ago, was possibly that moment, but it's still very tough. So because of, I know the client's got a mastoidectomy, he's got a mastoid cavity, the original part of the ear canal, the posterior part, you still see the rim of that, obviously once you clean the ear. So I'm just having to be extra cautious because I don't actually know where that rim is, because obviously it's all blocked. But you'll see, once I've cleared the ear, you'll see the original part of the ear canal. And then obviously you can see the extension, which is where the bone has been drilled away. You'll see the distinct area. And so I just still have to be careful because although I know this client's ear canal is widened, I want to avoid hitting the original part of the ear canal because some of it still exists, and again that would be very painful. So to the right there, it's just off camera, that's where the client's eardrum is, but you can see how far back to the left I am. And as I said before, these chunks are coming out a bit easier now. Still not easy, still quite tricky. I'm still having to work quite hard, wriggle, and you can see that's just layers of skin now, ribbons and skin starts being removed. The top part here is a bit crusty. You can see by the colour, the wax and dead skin's a bit darker. So if you've been watching some of my videos, as skin and earwax oxidizes, and it oxidizes when oxygen obviously reacts with it, and the longer it's been in the ear canal, the more likely it is to be oxidized. The wax and dead skin change colour. It changes from a pale colour, so with dead skin it's normally white, it then turns yellow and then to a dark brown. Similar with the wax, obviously wax doesn't start off white, it starts off a pale yellow, then a mid brown, and then a very dark brown, almost blackish. So I'm just here elevating the base of the skin. You can see possibly some dried blood there on that skin. You can just see how thick it is, how springy it is. And again, if you were to use forceps, maybe able to get a better grip now because it's elevated a bit more. But the likelihood is that I would, one, make contact with the bony part, which would be very uncomfortable here. And it may just shred it, and it'll just take a lot longer. So my idea here was to work this debris and dead skin off the canal. So obviously I'm watching this video back, but I think I was lifting it all the way around the edge of the ear canal. So here we're at the front, and you can see some dry blood there. So that blood is due to blistering. So when this skin, you can imagine how impacted and adhesive it is to the canal wall. And as you're lifting this, it does cause blistering. Um, and also the skin itself, it can get infected and cause an infection. It can cause a bit of osteotitis, so exposure of the bony part of the ear canal. And again, you can see all this white, thick coating, that's all dead skin. I'm just trying to get in a bit deeper and lift it, retract this from off the canal wall. So ENT surgeons, they use nasal retractors. So when they're performing nasal operations, if they're doing a septoplasty, for example, the septoplasty is the piece of cartilage and bone that separates the right and left nostrils, and you have mucosa, a lining of blood lined skin. So it's a skin that with blood vessels that supplies blood to that part of the body, and that's the mucosa. And they use an elevator and retractors to gently lift this mucosa off the septum to expose the cartilage and bone. And in a sense, that's what we're doing here. But obviously, we don't use retractors and elevators because the ear canal is rounded. I mean, maybe that's something I should try and develop, is some sort of device that you can, similar to what they use to retract the mucosa of the septum. The septum is more, generally speaking anyway, straight, although you do get deviated septums. But with septoplasties, patients are obviously under general anaesthetic or local anaesthetic, whereas with our client they're not. You can see here, I've managed to loosen that big ball of keratosis obturans, and the ear canal entrance is obviously more or less a normal size, and we've got an extremely enlarged ear canal there. So it's one job lifting and elevating, retracting this dead skin of the canal wall. I then have to bring that through a narrow opening, which you can see it was a bit of a struggle, but I did manage. Again, I was under the impression after removing that big piece that was it, that was everything. But you look back in there and you still see a lot of debris there, and it's mainly the skin. People with mastodectomies, it's just important you remove as much dead skin as possible. The last thing we want is this client to develop an ear infection due to all this dead skin in the ear canal, and it's vitally important I try as much as I can to remove as much debris as possible. So I think there now we're approaching the eardrum. It's still not fully visible. I think he was finding that a bit sensitive, and I'm going to go back in with a fine end at the moment, but it's very tough here. I mean, this has probably been in there for the best part of 20 years and kind of more medially near the eardrum. You can see it's a bit even more spongy and a bit more damp. That's most likely due to all the humidity. Imagine having all that debris in your ear for 20 years or so, and the increased humidity. It's going to make things damp. It's the perfect breeding ground for infection. You've got dead skin there, you've got humidity. It's a haven for bacteria really, but there is no active infection at the moment from what I can see. There's no arterial discharge. There's no real inflammation of the ear canal wall, so you just kind of see a nice fleshy pinky colour. You've still got ribbons of skin there. You saw a piece of ribbon removed. I'm just trying to unveil the eardrum. I'll give you some advance notice. I didn't manage to remove every little speck of dead skin and wax, and it's just, that's near on impossible. I would have probably been with the client for another an hour or so. But with the amount I've done, I'm very, very pleased indeed. And I've asked the client to use sodium bicarbonate drops on a regular basis to almost rinse his ear. As I said, sodium bicarbonate earwax drops works really, really well for dead skin. The patient does have to be careful, however, though, because sodium bicarbonate is water-based, it's alkaline, and if you overuse it, it can cause some irritation. During the procedure, I'm quite happy to use it as much as needed because obviously I can go in and vacuum it out, but there is a fine line that, again, we want to avoid an infection, getting the infection of the ear canal. So I just asked him to use it once every 2 weeks, and I've asked him to come back to me every 6 months actually initially to have his ear re-examined. You can actually now see the eardrum there, and he's probably had a radical mastodectomy, so some work done on his eardrum as well, and you can see it's a kind of a pink background there. Can't really see the landmarks of the eardrum, but that is the eardrum up there. You can just see by the angle it's kind of almost facing a wall, so that's not going any further. Um, just some dead keratin on the inferior part um, of the eardrum and the base of the ear canal. It's quite stubborn here, it's really impacted, and you can see me there trying to pull this away. It's almost mission impossible, unfortunately. I think I put some drops in just to soak it a bit more. Yes, you can tell it's softened it a bit more. It's still very difficult, very tough, but I did persevere for I think another 10 minutes, trying to remove as much as possible. And again, there's a clinical need for this. I'm sorry if people are finding this boring, but you'll see it at the end of the video, the amount of debris I did remove. It was quite shocking, and that's a lot of that debris is now being collected in this last 10 minutes or so of the video. These little remnants, shards of dead skin, caught ribbon skin. As I say, we need to remove as much as possible. And I've just talked for another 15 minutes there, I think, flat out. One of the reasons, and it's probably a good time for me to talk a bit more about myself, so my fans and subscribers, viewers can get to know me a bit better. I've always been very reluctant to do talkovers, whether it's after the procedure or even during the procedure. And there's a simple reason for that. As a young child growing up, I suffered from an extremely bad stammer and stutter. Happened during my primary school days, and it was very difficult. I think I hid it very well indeed. Part of the reason for that was I had breathing issues. I had a broken nose, still do actually, but my septum, and hence why I know a bit about the anatomy of the nose, I had a severely deviated septum, which has been partially corrected, so it's allowing me to breathe a bit better, but I suffer from extremely bad right nasal obstruction. That's where my septum has been deviated. And obviously you use your nose to breathe, but I was having to breathe through my mouth, and I feel as though it was that wasn't helping my speech, and I used to stutter a lot and stammer whilst at school. It was very difficult, and I don't believe actually some of my close friends even realise until now possibly that I had such an issue. People with a stammer and stutter, you've always had to think one step ahead. It's not so much that I couldn't pronounce certain words, it's when they're in a sentence and that flow of sentence, there's certain words that I know before I even say that word during a sentence that I won't be able to release from my vocal cords or from my mouth itself, the fricatives. So I would always constantly thinking of a substitute word, just like I did there actually. So it can be quite a lot of mental fatigue, because you're always thinking about what you're saying, and you're thinking ahead of yourself, kind of contemplating whether or not there's a word that's going to be coming up that you can't pronounce in that particular sentence, in that structure of that sentence. And it's one of the reasons why I decided not to continue with my PhD studies. So some of you may be aware that after I graduated from my BSc audiology degree, I went on to work as a senior audiologist, an audiologist within the NHS system, and it just wasn't for me. That's another story completely, but I then decided to apply for a PhD scholarship, and I applied for a medical research council funded studentship for a PhD at the University of Manchester, working under the tutelage of now Professor Kevin Munro, who's a world-renowned audiologist and audiological scientist and researcher. As part of a PhD, you have to do a lot of public speaking, and I just found it very difficult. A lot of my tutors, such as Professor Munro and another professor, Professor McKay, they found it very difficult to believe me almost, because they never noticed that I had such an issue, because they felt I always spoke so very well in public. But I found I used to suffer from a lot of anxiety, because I was always worried about my stammer and stutter returning, and doing that on a live public stage is quite daunting. And I decided after passing my first year that actually I was finding it too difficult, and I was getting too anxious, and not only that, but I was missing the clinical side, so I decided not to continue, unfortunately, with my PhD, much to the regret of Professor Munro and Colette McKay. We had a great first year working together, and my thesis was going very well indeed. And I decided to open my own private audiology practice. Sorry, you can see, I'm going to just go back to there. Now, remember earlier I told you you could see you'll be able to see, once I've removed all the debris, the original ear canal wall. And you can just see it on the right hand side there where the suction probe is. So the suction probe is in between the original ear canal wall. You can see it kind of, the bump going to the right and over. And to the left is the extension of the ear, if you want to see it in that way. That's the mastoid cavity, and you can see that clear distinction, that wall right in the middle of the shot at the moment. So that's where the client's original ear canal would have been, and where I'm working now is the new part of the ear canal. That's the mastoid cavity. So sorry, I just wanted to come back to that. I think I was talking about the reason why I left my PhD. My stutter and stammer has over the years undoubtedly got a lot better, in the sense where I'm able to manage it a lot more, partly because my breathing has significantly improved, but also I'm finding that I'm doing a lot more public speaking in general. I'm coming out of my comfort zone. I like challenging myself. I felt I possibly should have done that a bit more actually in years gone by, but I've done a lot more radio interviews, obviously work for TV like Which Magazine, and just generally getting more confident and comfortable in front of the camera and speaking like I am, which is completely live, unscripted. We're coming to the end of the video, I believe now, so I did talk quite a lot there, but again, it's only so much I can talk about the procedure. I'll just be repeating myself like a parrot if I kept just saying I'm using a suction probe, removing that skin. But I'm really pleased with what I've done there. I've removed the majority of dead skin. Any bits that I didn't, it was just too impacted, and the client was going to use some sodium bicarbonate drops and return to me, but he was extremely over the moon, as you can imagine, and that is all that debris and dead skin, keratosis obturans, earwax that I removed from this ear. So it's quite a remarkable feat. I don't think I've ever removed so much debris from one ear, and reading the comments after uploading these very still images on my Facebook page yesterday, I don't think a lot of my followers have ever seen anything quite like this, and that makes two of us. So I don't know whether it goes down in the Guinness Book of Records. I have previously removed the largest documented piece of earwax from an ear canal, which is almost 3 centimeters in length, which is the entire canal in a single piece. But I don't think there will probably be such a record in the Guinness Book of Records for the quantity of wax, but it's there for all to see. And that's just from one ear. I hope you enjoyed that, guys. I've got a very dry mouth now. That's almost constant talking for the last 40 odd minutes. I'm now going to upload this video, which will probably take me another half an hour. It's 9:15, and hopefully I can possibly catch the second half of any football. If not, I'll watch the highlights. But I really wanted to get this video up for everyone, especially one person individually. Her name's Caroline. She's a good friend of one of my best friends, Sarah Vokes. Sarah and her husband Ian, they're both have her own audiology practice in Nottingham called Correct Hearing. I'm going to give them a bit of a shout out. They're a fantastic audiology company. I've known them for about, how many years, Sarah and Ian? I think we went to America together in 2013, so the best part of 7 years. And Caroline is a good friend of Sarah, and Caroline was telling Sarah that she was watching the Wax Whisperers videos, and little did Caroline know that me and Sarah are very, very close friends. And when Sarah mentioned to Caroline, well, me and Neil are very close, we're like brother and sister, Caroline did not believe Sarah, so Sarah had to FaceTime me and prove to Caroline, who was having dinner at the time. So there you go, that's Neil, that's the Wax Whisperer. And Caroline's been a great support since, but she can be a tough taskmaster, constantly telling me to upload videos. So this one's for you, Caroline, and also all my other fans. Value each and every single one of you. And if this is the first time you've watched one of my videos, do subscribe, click the bell icon to get notified as and when I upload new videos, and feel free to view all the other videos on my YouTube channel and Facebook